Hello students, welcome to the discussion of the MCQs in the topic respiratory system. So we take the first question here. A 7-year-old child has been diagnosed to have intermittent asthma. Best management in this child is. Now according to the XINA guidelines, in the intermittent asthma, what we are giving is inhaled short acting beta agonist plus inhaled corticosteroids, and they both are given intermittently. SABA alone is not given. You are giving both of them, but you are giving them intermittently, not in the daily basis. Second one, a 1-year-old child is suspected to have mild persistent asthma. Low dose inhaled corticosteroids are to be given. So first thing you should remember, in the mild persistent asthma, the treatment is the low dose inhaled corticosteroids. The best way is, now this is a 1-year-old child. If you only use a spacer along with the powdered meter dose inhaler, that is not sufficient. A mask is also required. So the right answer here particularly is this. There is powdered meter dose inhaler plus spacer plus mask, right? So because it is a 1-year-old child, this is particularly mask is to be preferably used here. Next one, a 14-year-old female, known case of cystic fibrosis, presents with increased sputum production, dyspnea and weight loss. On examination, there is 15% decrease in FEV1. She was started on tobramycin, but no improvement is seen after 10 days and FEV1 is still low. Which of the following is the most likely cause? Now this is a 14-year-old female. So if you basically consider most common cause of respiratory tract infection in second decade in cystic fibrosis is Pseudomonas aeruginosa. Pseudomonas aeruginosa, and that too mucoid strain. And if it is Pseudomonas, it should respond to tobramycin. But if it is not responding to tobramycin and there is decrease in FEV1 in spite of receiving antibiotic, you should consider is the allergic bronchopulmonary aspergillosis. So this is ABPA, allergic bronchopulmonary aspergillosis. An 11-year-old female with cystic fibrosis F508 deletion homozygous is taking the triple combination of elexacaftor, ivacaftor, tezacaftor. The child also develops aspergillosis as confirmed by bronchoalveolar lavage and is started on oral voriconazole therapy. Which of the following parameter needs to be monitored in this child? Now this basically all are CFTR modulators or CFTR correctors, and they all are hepatotoxic. They all are hepatotoxic. And the antifungal drug voriconazole, that is also hepatotoxic. But what is more important is this, both of these drugs, maybe this one, the CFTR modulators, which includes elexacaftor, ivacaftor, tezacaftor, and this voriconazole are metabolized by liver. And voriconazole, this is an inhibitor of the enzyme CYP3A. So if this inhibit the hepatic enzyme, this particularly concentration of this elexacaftor, ivacaftor, tezacaftor will increase, right? So if their concentration will increase, there are chances of hepatotoxicity. So you should go for the liver function test. You should go for the liver function test. Voriconazole will inhibit the enzyme CYP3A. So what basically will happen? The concentration of the CFTR correctors will increase. They are hepatotoxic. So remember what is required to be done here. Liver function test is there. Next one, a 2-month-old child with 2-day history of nasal congestion and fever has severe respiratory distress and decreased feeding in the last 24 hours. There is diffuse bilateral wheezing with fine crabs, right? Now age is particularly 2 months, coming between 1 to 6 months. Initially upper respiratory infection. There is diffuse bilateral wheezing and fine crepitations. Respiratory rate is increased. that is 70, SpO2 is 88%. So our basically diagnosis is bronchiolitis, because bronchiolitis will present with what features? Fine crepes, bilateral, right, and there is bilateral wheezing which is also present. So in this case, what we say, there is no role of antibiotic. So what we just simply start is the humidified oxygen therapy, and we maintain the hydration. In bronchiolitis, just remember, no particularly steroids we say here, and there is no antibiotics. No antibiotics. Next one, a fully immunized 2-year-old presents to the emergency room with several days of low-grade fever, barking cough and noisy breathing. Over last few hours, he has developed fever up to 40 degree and looks toxic. He has inspiratory and expiratory stridor. So one is the barking cough, one is the stridor. Family has not noticed drooling. Drooling is basically an acute epiglottitis. That is particularly not here, and he seems to be drinking without pain. No dysphagia is there. So that means this particularly rules out epiglottitis. So there is no role of particularly antibiotics. So this is basically a case of the Croup, right? That is laryngotracheobronchitis. So what is supposed to be given here? Inhaled epinephrine or oral steroids. So which can be beneficial. So these two drugs can be beneficial depending upon the condition of the child here. You evaluate a 5-year-old boy with history of chronic and recurrent upper respiratory tract infection. The point is recurrent upper respiratory tract infection, several admissions to the hospital for pneumonia, and 3 surgeries for chronic otitis media. That is an important thing. Of note, there is a right-sided heart on repeated radiograph. There is so-called dextrocardia. There is otitis media. There is frequent respiratory tract infection. All of them goes in favor of the immotile cilia syndrome. That is particularly the Kartagener syndrome. That is particularly the Kartagener syndrome, immotile cilia syndrome. So on the basis of history, a biopsy of the nasal mucosa is expected to reveal which of the following? Biopsy of the nasal mucosa is going to reveal the nasal polyps. That is something, a finding you get in the Kartagener syndrome, and in this the eustachian tube is also affected, because cilia is affected. The cilia of eustachian tube is affected. That's why there is frequent otitis media which is seen in this condition. Next one, a 5-month-old infant develops signs of respiratory distress after coughing and sneezing for 3 days. He has marked subcostal and intercostal retraction, respiratory rate of 80 breaths per minute, diffuse crackles can be heard bilaterally, no stridor. That is there. Arterial oxygen saturation in 100% oxygen by mask is 88%. Skin is pale. Peripheral arterial pulses are weak. Now this is a significant point. Peripheral arterial pulses are weak. Which of the following is the most important immediate course of action? If we read the choices, administration of corticosteroids, no. Intubation of trachea and mechanical ventilation. Respiratory rate is high but SpO2 is not that much low. Sampling of arterial blood and measurement of arterial pH and blood gas. Administration of normal saline. So the first step should be administration of normal saline as the peripheral pulses are weak. After this, the presumptive diagnosis here again can be bronchiolitis. Bronchiolitis, because initially there was sneezing, URI, then there is diffuse crackles which are present bilaterally. So after this, you will be followed by, you will be giving is the humidified oxygen. We will be particularly giving here is the humidified oxygen here. Next one, in a child there is a history of frequent respiratory infections and failure to thrive. Sweat chloride levels are estimated 35 and 41. What is the next best test? So frequent respiratory infections, failure to thrive, which can be secondary to fat malabsorption, which is seen in cystic fibrosis. So if we are thinking of the cystic fibrosis, always to confirm, first we go for sweat chloride level, which should be more than 60 on 2 different days. That is there. Then the second is DNA analysis of CFTR mutation, and 2 or more than 2 CFTR mutation should be there. 2 or more than 2 CFTR mutation should be present. A 6-year-old child with a history of recurrent cough and wheeze underwent a pulmonary function test. Findings are seen. Next step is. Now you can very well see from the graph this one, and if you particularly see here FEV1 by FE1C ratio, right, that is basically decreased, right. So this is basically an obstructive picture, obstructive. So there is a wheeze, recurrent cough, you are thinking of asthma. But based on this spirometry, just on a single finding, you don't go for. You want to know whether this airflow obstruction is reversible or not. So you want to know the reversibility of airflow obstruction. For this, what is supposed to be done? Do bronchodilator test. And if you get more than or equal to 9 to 12% increase in FEV1, this suggests asthma. So you don't start treatment just by saying this is an obstructive. You also want to know whether this obstruction is reversible or not is there, right? So this was some of the questions of the respiratory system. Thanks for watching. You can follow me on this channel, Telegram group, on the Instagram. Thank you for your support. Do subscribe to the channel. Thanks.